Hello, everyone. Thank you for joining today's briefing, Improving Healthcare for People Experiencing Homelessness. I'm Madeline Cree, Health Policy Analyst at the Alliance for Health Policy. For those who are not familiar with the Alliance, welcome. We're a nonpartisan resource for the policy community dedicated to advancing knowledge and understanding of health policy issues. Today's briefing is brought to you in partnership with the SCAN Health Plan. Before we begin, I'd like to remind everyone that you can join today's conversation on Twitter using the hashtag AllHealthLive and join our community at AllHealthPolicy, as well as on Facebook and LinkedIn. Now I'd like to introduce Dr. Sachin Jain, CEO of our partner organization for today's event, SCAN Health Plan, who's going to kick off today's event with some opening remarks.
Hi, everyone. My name is Sachin Jain, and I'm the president and CEO of SCAN Group and Health Plan. I am thrilled to be with you here today, and SCAN is thrilled to be sponsoring this special session on homelessness and healthcare. I first became interested in this topic when I was an undergraduate student volunteering at a homeless shelter and saw the intimate connection between healthcare issues and homelessness. I saw that healthcare issues were oftentimes the reason that individuals became homeless, or very often were the reasons that individuals were often remained homeless or stayed without housing. I believe that we have an opportunity in this country to reframe the issue of homelessness, which has oftentimes been characterized as a housing supply issue, to be both a housing supply issue as well as a healthcare issue. I think we have tremendous opportunities from a policy innovation perspective to use both the Medicare and Medicaid programs to better serve the needs of people experiencing homelessness and actually reallocate resources that are presently applied to addressing complications from homelessness and instead focus on both preventing homelessness as well as addressing the needs of people experiencing homelessness. What do I mean by this? I mean that our healthcare system is oftentimes very comfortable addressing a gangrenous toe and sepsis in an ICU at a cost of hundreds of thousands of dollars in place of actually upstream preventative care to ensure that people are well and healthy and independent wherever they reside, whether it's in their homes or on the streets. SCAN is investing very heavily in a new street-based medicine program that's actually focused on applying the principles of managed care to really prevent downstream complications of people experiencing homelessness and address their behavioral and physical health needs on the streets where people reside, with the intent of trying to stabilize their health conditions and hopefully getting them to a place where they may be sustainably housed, either through temporary housing that leads to permanent housing or through reintegration into their community and social safety nets. This is, one of our biggest problems. And if you live in Southern California, you see people experiencing homelessness every day, and you see the suffering that they endure. We want to be part of the solution, and that is ultimately what we're here to discuss today, is how we as a society can reframe the problem of homelessness, think differently about how to address it, and ultimately drive sustainable solutions through existing policy instruments that can ultimately lead to real solutions for people who need it most. So I'm thrilled that we're partnering today with the Alliance for Health Policy, thrilled that we have an amazing group of speakers who are very skilled and knowledgeable about these topics. And I'm hoping that we can start a dialogue that will continue into the months ahead about how we can actually take this problem that I frankly think is an embarrassment to our society and apply some real sustainable solutions to address it. Thank you very much.
Thank you, Dr. Jain. Before we continue today's conversation, I do have a few quick housekeeping notes. I'd like to remind you that today's panel has a question and answer session, and we want you all to be active participants, so please get your questions ready. You should see a dashboard on the right side of your web browser that has a speech bubble icon with a question mark. You can use that speech bubble icon to submit questions you have for our panelists at any time. We will collect these questions and address them during the broadcast. Throughout the webinar, you can also chat about any technical issues you may be experiencing, and someone will attempt to help you. And now I'm so pleased to introduce today's moderator, Ms. Ellen Lawton, Senior Fellow at Health Begins. Ellen is a national expert in the integration of legal professions into the legal professionals into the healthcare setting to address the social determinants of health. She helped found and then led the National Center for Medical Legal Partnership at George Washington University. And Ellen is internationally recognized for her leadership in developing the medical legal partnership model. She's a recipient of the Innovations in Legal Services Award from the National Legal Aid and Defender Association as well. Ellen, I'm so pleased to leave this discussion in your expert hands, and I will turn it over to you. Thank you so much.
Great. Thank you so much, Maddie. And thank you, Dr. Jane, for your opening remarks. And I'd like to kick us off by introducing today's panel of experts. I'm so pleased to be with them today. And first, we're joined by Dr. Barbara Dipietro, who's the Senior Director of Policy at the National Healthcare for the Homeless Council. And in this role, Dr. Dipietro conducts policy analysis, provides educational materials, and presents to a broad range of policymakers and other stakeholders. She also coordinates the Council's policy priorities with the national partners and organizes staff assistance to the policy committee. Next up is Mr. David Peary, who's the co-chair of the National Consumer Advisory Board at the National Healthcare for the Homeless Council. And Mr. Peary is a passionate advocate seeking to end homelessness throughout Florida while leveraging his legal training advocating for homeless rights. When David experienced homelessness, he was led to Camillus Health Concern, where he became a member of a struggling consumer advisory board and really attempted to regain the consumer voice in governance, focusing on educating and empowering consumers to take control of their healthcare. In his deep commitment to advocacy, David is a class representative in a federal class action lawsuit that establishes the rights of people experiencing homelessness in Miami and works to combat the criminalization of homelessness. Finally, I'm pleased to introduce Dr. Jim O'Connell, founding physician and president of the Boston Healthcare for the Homeless program, which serves over 11,000 homeless persons each year. Dr. O'Connell established the nation's first medical respite program for homeless persons at the Lemuel Shattuck Shelter, and he designed and implemented the nation's first computerized medical record for a homeless program. In addition to his role with BHCHP, Dr. O'Connell serves as an assistant professor of medicine at Harvard Medical School and actively practices street medicine to deliver healthcare to people experiencing homelessness in the city of Boston. Welcome to our panelists. We're so glad that you can join us today, and I want to get right into it. So I'm going to turn it over to our panelists to offer some opening remarks. Barbara, can we start with you?
Great. Thank you so much, Ellen. Really appreciate being here and really appreciate so many of you joining for this topic. Just quick note about the National Healthcare for the Homeless Council. We're a membership organization comprised largely of federally qualified health centers that serve people experiencing homelessness, but also medical respite programs, consumers, researchers, and other advocates who are looking to improve the healthcare system and end homelessness. We provide training and technical assistance, research, policy analysis, and advocacy, and all the good things that we need in order to get our communities doing better healthcare for people experiencing homelessness. Next slide, please. Just wanted to level set a little bit about homelessness in the United States right now. So every year, HUD, the Housing and Urban Development, tasks communities with doing a point-in-time count. So on a single night in January, particularly in 2021, there were a lot of issues with this. Obviously, COVID has made things very hard. Counting people experiencing homelessness also comes with its own challenges. But over time, we've at least been able to get somewhat of a snapshot of what we see again on any given day. And what we see is not good. We have over 580,000 people who were able to be counted as homeless on a given night in January, and wanted just to spend a moment to look at what that demographic looks like, just again as a snapshot. So partly it's to appreciate that homelessness looks lots of different ways, and everyone has a different story. So this idea of brandishing with one brush, this as being a behavioral health issue, an addiction issue, something like this, is not really appropriate, because again, while those may be factors that are present, they don't characterize the whole. largely it's really important for us to center this entire discussion on the lack of affordable housing in the United States. And so that's what's driving homelessness. However, when we look at who's experiencing homelessness, we're seeing a lot of people on their own, but we also see a lot of people in families. Now, one of the things that we can tell you, and Jim and David certainly can also add to this, is what happens to families experiencing homelessness over time. They tend to separate. And so you see a lot of individuals who are experiencing homelessness did come from families. But when we don't intervene quick enough, particularly before someone loses a job or loses the ability to pay rent, that's when we've sent a family into crisis. It's also important to see that about 40% of people who were homeless are unsheltered. This is really speaking not just to the lack of affordable housing, but to the lack of dignified alternatives. So our shelter system is stretched to capacity, and particularly during COVID, where we did social distancing and a lot of other provisions in shelters, we weren't able to serve as many people. Many communities opted into hotel or motel programs so that we could get people off the street, particularly those that were increased risk of COVID infection. But still, we're seeing a very large segment of unsheltered population. And then within the shelters, we're seeing a lot of families and kids. So just want to appreciate kind of the different demographics that come with a larger population. Next slide, please. So I think in the context of healthcare, and again, we want to root this in the lack of affordable housing. So when we say housing is healthcare, that's where we're coming from, is that nothing that we do as healthcare providers works as well if someone goes back to the shelter or under the bridge or to the encampment. Stable housing is important for stable health. So when we look at, for example, the disparities in illness and in the conditions that we're treating in the healthcare system, when you're experiencing homelessness, you're going to be experiencing diabetes and hypertension and other chronic illnesses at a far higher rate than the general public. And this is true for chronic medical conditions as well as behavioral health and mental health and substance use disorders. One of the things that I'm sure Jim certainly in doing this work for decades can say that back in the 1980s, the Institute of Medicine, as it was, and now the National Academies of Sciences, they put out a study in the mid-80s about homelessness and the rise of this endemic issue in the United States. And they found three things. One is that poor health causes homelessness, whether that's medical debt, whether that's an illness or an injury that just got worse to the point where someone lost housing and couldn't afford care. It also found that homelessness exacerbates existing health conditions, but also creates new ones, because homelessness is a very difficult, traumatic event. And then because homelessness is traumatic, it also makes it hard to engage in healthcare when you are homeless. There's a lot of other things going on to ensure your survival, and managing your diabetes or your chronic health conditions may not be at the top of the list when you're struggling to find food and a safe place to put your head. So all of these things combine where homelessness creates significant healthcare struggles for individuals, and then as a result, that creates significant struggles for the healthcare system serving them. Want to also mention that we can't have this discussion without talking about structural racism. And I don't think it's an accident in our public policy that African Americans and Black and brown populations are overrepresented in the homeless population compared to the general public. So when we think about the public policies that create homelessness faster than we can end it, and we think about the public policies that have pushed more people who are Black and brown into poverty and into homelessness, those are the honest conversations that we're hoping to have here today. With that, I am going to turn it over to my colleague, David Peary, who can talk with you more about what all this looks like from a personal perspective that he brings to this conversation. So David, I'll turn it over to you.
Okay, thank you, Barbara. So yes, my name is David Peary, and I'm co-chair of the National Consumer Advisory Board, which is a network within the National Healthcare for the Homeless Council. And I'd like to present a perspective from the streets, perspective of individuals who are unsheltered, and talk about some of the barriers, or perhaps conversely, access points that may be available, either prohibit or may be available to folks seeking health care. And many of those barriers are set out onto the slide here, onto the bullet points of the slide. One point I just want to make that's on the slide, that's the overall point here, is how intensely traumatizing homelessness is. And in fact, I think unless you've actually experienced it, you have no idea how it affects quite literally every aspect of your thought pattern, everything that you possibly would think of throughout the day. You're simply in survival mode, and you're also in a protective mode to protect yourself against your vulnerabilities. So I just want to just make that very clear as an umbrella concept, that homelessness is intensely traumatizing, which leads to the remedy, or at least the approach that we need to take a trauma-informed approach, which I'll talk about in just a moment. But this first bullet point here is extremely important in my home state, such as Florida, and the other dozen or so states that have failed to expand Medicaid. That the failure to expand Medicaid is not only a moral failure, I would contend, but also a public health failure. That Medicaid is obviously the access point that people have who are entrenched in poverty to accessing health care. And we can see the effects, the concrete effects that manifest themselves every day here in our non-Medicaid expansion states, such as Florida, that individuals who lack access to primary care, lack ready access to behavioral health services, obviously have to wait until some type of health condition reaches a crisis point that they get admitted to a emergency room, to the ED. And I don't think it needs an explanation to anybody on this call here that obviously once it reaches that point, it's going to be obviously much more costly, much more difficult to treat, and it's going to have much worse outcomes. So I would simply add to this first bullet point and emphasis that failure to expand Medicaid is not only moral, but it does have significant public health consequences to individuals who really have Medicaid as the primary point of access to health care, or who would have it if it was available to them. The second issue, and that actually folds into this second issue of the broader issue of lack of access to primary care, behavioral health, and supportive services. And that affects really the poor, people immersed in poverty in general, as well as the people who are specifically living on the streets. We do have access to the wonderful system of community health centers, of which the health center that I'm affiliated with, Camilla's Health Concern, here in Miami, Florida, many do have access to primary care, behavioral health, and support services within the network of FQHCs, federally qualified health centers. Unfortunately, that network is not extensive enough to be available to everyone on the streets. So again, even when you are in states that apparently have expanded Medicaid, folks that are living on the streets, unsheltered, entrenched within poverty on the streets, don't always have access to those primary care services. And that manifests itself in very significant effects and adverse effects on their health. What we have here is summed up a huge problem here in Florida and Miami in particular in the third bullet point, the problem of hospitals discharging people onto the streets. That is major, that is significant. We do know that there are federal regulations, laws, if you will, that advise hospitals not to do so, perhaps even prohibit hospitals or penalize hospitals from discharging people who are unhoused onto the streets, who are not sick enough to fit within DRGs, not sick enough to be maintained within the short-term acute care setting, but are way too sick to take care of themselves on the streets. And so there's this new industry, I think, that popped up in a few years that recognizes this, called transitional care. However, huge, we have documented many instances here in Miami, and in fact, these instances happen quite literally on an everyday basis, where the local hospitals have no place else to discharge individuals, where the case managers at the discharge planners are working overtime and quite literally are at a dead end in terms of being able to place individuals in any type of transitional care setting. And that has had devastating consequences. We have what's known as an MSM, a medical street, a street medicine team here in Miami that's actually documented specific instances of individuals not only having adverse health effects, but actually dying across the street from the hospital. And I'll repeat that. We have documented instances in which an individual who was discharged onto the street has died, several instances, as a matter of fact, quite literally just either across the street or right down the block from the hospital. So this has devastating, horrific effects. And we are, many of the public health professionals here locally are looking to see what we can do to establish medical respite care programs, which I think were pioneered by Jim McConnell, one of the other speakers on this panel. This next bullet point here, lack of effective outreach, is a big problem. Many people on the streets are, because of the vulnerabilities, because we've been so traumatized and abused by folks that we think would ordinarily be protectors, like the police, that often turn out to be predators in terms of criminalizing homelessness. There's simply a lack of trust among many unsheltered people on the streets when it comes to connecting individuals to healthcare services. Many of the individuals, unfortunately, who conduct street outreach are not effective because they tend to look down or they have what's known as maybe a judgmental attitude towards folks. So it's extremely important to use a trauma-informed approach, not so much to ask people what is wrong with them, but more to ask people what happened to you to get you to the spot to where you're at. Stop looking at the purported moral or character failures of individuals and look at the systemic issues that have caused people to be on the streets. And when you start to ask those questions about the systemic structural issues, you take a trauma-informed approach. When you reach people where they are at, instead of trying to coerce them into a different level, that's when you start to build that trust and you get effective outreach. And what we found is that the most effective outreach are individuals who have surmounted those challenges themselves. Peer support specialists, for instance. Peer support is an excellent, effective way to reach people, which leads a segue into this next bullet point here. There's a need for peer supports, community health workers, and trauma-informed approaches that use a harm reduction philosophy. Along those same lines, we have found here in Miami that we have a pioneering syringe exchange program that has proven itself to be very effective in getting people within that continuum to allow them to receive healthcare services. So folks that would go into the syringe program, injectors and the like, would then get care, for instance, for wound care services or for hepatitis or things like that. And then that would then allow them to get healthcare services for other issues that they may have. And I have personally known of many individuals who have taken advantage of that to eventually get permanent housing. This last bullet point here is, again, a fairly significant issue on public health to individuals. That's basically the criminalization of homelessness. The criminalization of homelessness that we're finding out here, specifically here in Miami, has significant health effects, adverse health effects on individuals. The city unfortunately engaged in a series of aggressive cleanups to justify dismantling of homelessness encampments, even during the COVID crisis, against CDC guidance. And we have found that when they come through, they trash everyone's valued possessions, they destroy medications, walkers, wheelchairs, canes, and the like, that we see significant health effects on individuals hours later. We have documented instances of a woman going into convulsions on the street because her medication had been thrown away by city workers just hours earlier. And we do have documentation of individuals who are disabled, who have had their walkers and wheelchairs thrown away. And again, this is simply under the one component of the criminalization of homelessness. So I can go into many different examples here, but the bottom line is, one of the best way to improve the health of individuals on the street is sort of like a flip of the Hippocratic Oath of do no harm, is to stop it, stop doing the harm, stop criminalizing individuals, for being so poor that they cannot have a home and that they're forced to conduct life-sustaining activities on the streets. So at that, I'm going to turn things over to our next speaker, which is Jim O'Connell of Boston.
Excuse me, David, thank you so very much. And hello to everyone out there in the audience who we can't see, but it's an honor to follow both Barbara, who's been a hero of mine for years, and David, who has the immense respect of all of us around the country for helping us with our consumer and legal issues. I also wanted to say, I'm so sorry my audio didn't work for Such and Jane, but I wanted to just acknowledge what a hero he has been to all of us. And I'm so sorry I did not get a chance to hear him, but please send in my best. I thought I'd take a perspective from leading from David into how we sort of got started here in Boston. And interestingly, we began in 1985 with a grant from the Robert Johnson Foundation, a foundation I'm sure you've all heard of. But one of the things they did very interestingly was say the grant was given to the mayor of the city. What they said was that there needed to be a coalition of stakeholders who would decide how they wanted the model of care to look. So we never had anything to do with how we currently look, as much as I'd love to claim it. It really came from these folks. And I wanted to show this picture of our consumer board, consumer advisory board back in the 90s. But the woman third from the left on the bottom is Ellen Daly, who David will know very well. She was just a force in our lives, a woman who was homeless, had very interesting medical problems, and she helped with the National Healthcare for the Homeless Council in forming the National Consumer Advisory Board. But this group, just to let you know on the next slide, came up with how they wanted to be served, what they thought was right. And this goes back to 1984 when they were meeting at City Hall and putting their fingers at the mayor and saying, here's what we need. But their issue was continuity of care. What they were looking for, they had felt their lives were full of fragmentation, full of loss. The last thing they wanted in their healthcare system was more fragmentation. So they were insisted that there should be continuity of care from shelter and street to the hospital. So in an interesting part of our program, which I think has defined much of what we do, is that we have to stay part of the hospital. So all of our docs and nurse practitioners and PAs have to be credentialed and working in a hospital, one of our two main hospitals, but then do our clinics out on the street and go to wherever people are. Because they said, as David had mentioned, survival on the streets and in the shelters, it has an immediacy that makes it very difficult to make an appointment Friday at 2 o'clock or next week or a month from now. So they wanted their clinicians to come to them. And so most of our model has been clinics during the day in the hospitals and clinics in the afternoon and night in the shelters, and all integrated in one. The other thing they did, which was interesting here, is they said, please work in multidisciplinary teams. And I thought that was an early thing of, doing collaborative teamwork. But what they were worried about, to be very frank, is continuity. And they were worried about people like me, people who were going to do good and go do, I was going to give a year of my life to doing this program and then move on and do my fellowship in oncology. But they didn't like that idea. They wanted to say, if you're going to be our doctor and our healthcare team, we want you to do this as your profession and not as something you just do as a temporary thing that you move on, especially if we're going to open up and let you into our lives. So they wanted us to work in teams. So I've never had my own panel of patients. I've always worked with a nurse practitioner, a PA, and now a psychiatrist and a recovery coach. And we share in the same panel of patients. So if any of us happens to leave, those homeless folks have a team of providers that they know. Last thing, by the way, this looks to me like early 1984 version of a patient-centered medical home, by the way. Kind of interesting how the folks on the streets were really way ahead of us. The last thing they asked, though, was to establish respite care. And that's the first time I'd ever seen the word respite care. So this is 1984. I was coming out of the residency. I had no clue what they meant. And in the next slide, I wanted to share, this is the earliest picture I have of our respite program. So we were it was in the middle of a TB epidemic in Boston, and we were given 25 beds in a corner of a shelter, and we had to try to figure out what respite care was. And it basically was for people coming out of the hospital way too sick to withstand the rigors of a life on the streets or in the shelters, but they had no homes to go to. So we had to provide sort of nursing and doctoring around the clock so that people would be okay. And as you can see here, it's a variety of illnesses from heart failure to frostbite injuries. And what happened though in 1985, right after we opened this in September, the first person to be diagnosed with AIDS in the homeless community of Boston came in. And within a few months, we were really essentially had become an AIDS unit. And then the next slide, and I realized as we were talking about this, that we were conceived back then in these twin epidemics of a multi-drug tuberculosis outbreak and the AIDS epidemic. And it feels like the bookends of my life when I think of COVID coming, and lots of reminiscences about what we went through in the mid 80s to what we're going through now. But in a frame shift, because the lens that I see, I think homelessness, by the way, we should share this, and we've talked about this a lot. Homelessness suffers from a complexity of need. There are so many angles of homelessness. There are so many different groups who are experiencing homelessness. It goes, there's old and young. There are people that have been through trauma. There's people with medical problems and disabilities, people that have learning disabilities, mental health issues, you name it. And it's a very complicated mix. So it's very hard to make sound bites that work. And the lens that we happen to look at our homelessness, because we were given this as our mandate, is how do you take care of the health of people who are homelessness? And that turns out to be, as you've heard from Barbara and from David, actually very difficult for systems that are set up, assuming you can come to them and you have a safe home to be in. Anyway, this picture is one I share with all the time. It was taken by a homeless woman who lived under a bridge we call the Longfellow, that is called the Longfellow Bridge, right next to Mass General, which is my home hospital. And it was a picture she took with a throwaway camera right at the turn of the century of her friend sitting in a park. And there's about 10 or 11 or 12 men there, and there's one woman who's hiding behind a man. But when I didn't see this picture until she was going in for surgery about 5 years after she took it, she handed me her belongings to hold on to while she went for day surgery, which is a very common problem, by the way. Imagine you're homeless and you need to do anything like day surgery. You have to bring all your stuff with you or put it somewhere safe, and you have to be able to get the surgery. You need to really have someone who's able to take care of you. But anyway, when I look at this picture, I knew everybody there, and it was 5 years later, and I was stunned by two things, just to throw this into the conversation mix. One is, these are young men, average age is about 36 years old, and they are all, because we're Massachusetts, they all have Medicaid. They're all insured because we had Romney Care back then. And essentially, all homeless people in our town now have access to health insurance. They're also, the second thing was good, they're sitting in a park at Mass General Hospital. This is on the grounds of our hospital, and I would argue we're a pretty good hospital. We're very proud of what we do. But when I looked at this picture 5 years after it had been taken, there were basically just one of those people still alive. So when I think of what goes on in the next slide, on the streets and in the shelters of our communities, mortality rates are astronomically high, and it's very complicated. We look like a third world country results, despite the fact that we're working in the shadows of our best healthcare institutions. And surprisingly, the causes of death were sort of interesting. It was cancer, the leading cause of death. It was not what I thought it was going to be, like drug overdose or assault, cirrhosis, cardiac disease, and everything. So if you look at this, you start to realize there's a whole, as Barbara suggested, there are huge medical and psychiatric issues which overlay the experience of being homeless. And some were pre-existing, some are caused by that, and others are created afterwards. But anyway, the care of these folks is complicated. And in the next slide, I wanted to just end up by saying what we have had to do and what we keep trying to do is recognize that we have to hold two things in mind. One is that the solutions to homelessness go back to the roots of society, and we need those. We have to fix our schools, we have to fix our welfare systems, our education, the whole system, and we have to provide the housing for the platform for doing it. But in the meantime, we have in the country, as Barbara showed, thousands and thousands of people who are experiencing homeless and are sick and need care. So those two things are the two things we have to hold at the same time. And one of the things we've learned now, so we have clinics in most of the shelters of Boston. Our doctors and nurses are in there, and they're integrated with our clinics at the hospital. And we need the hospital because, as you can see, people have very complicated medical and psychiatric issues and behavioral health issues. But we learned that there are some advantages to the trust you earn by being out there on this. And so during COVID, which was devastating for us, 35 to 40% of everybody living in Boston shelters got COVID. We did all sorts of things, which I won't bore you with, but we've also now been vaccinating, and with an interesting twist. So this is one day in that same park that I took that picture, where that picture was taken in. And this is Jen, our nurse practitioner, our physician assistant, giving shots. This is vaccinations to the people on the street. And about 75% of everybody living on the streets of Boston has been vaccinated. And they're vaccinated not because we have any twist to it, but because the vaccine was given to them by someone they've known for years. It's not someone coming in who's trained. And in the shelters at any given time, because with the denominator changes, somewhere around 80% of the people were vaccinated through the clinics that we've had for years in the shelters. So I have a feeling that what we've been working toward is making sure that the population of homeless people who have these huge burdens of co-occurring medical and psychiatric or behavioral health and substance use disorders, that for that group of people who are homeless, really setting up a healthcare system that blasts through the boundaries and obstacles that we usually have and integrates their care right where they are. So we have a psychiatrist on the street working with our nurse practitioners and our recovery coaches, all caring for the same people. It really makes a big difference. At any rate, I am going to stop here. Or maybe let me go one more slide or two more slides, if you would. What's the next slide? I don't want to go. I thought I'd share this with you because we in Boston, and we may be talking about this, have a real issue with a new encampment that's come up over the last several years, and where we thought only 3 to 4% of everybody in Boston who was living on every homeless person in Boston was living on the streets. It's now shifting as we've had difficulty with sheltering. COVID came along, and now they're in large encampments. And and COVID, along with the encampments, has given us a real compassion fatigue, if I could say that, and there's a real burnout in clinicians around, not only with us, but around the country. But I remember this was 30 years ago in the New York Times, and it was Labor Day, and there was as you can see the headline, there was a shift in feelings in the homeless where empathy had been turning to frustration. And I fear that we are in a 30-year cycle, and that is what I worry about now. And I would urge you all to realize that there is a human tragedy behind what is going on. And as David pointed out so eloquently, sweeping it away or getting it out of sight is really not addressing this public health emergency. Thought you might be interested is the New York Times correspondent who wrote that was Isabel Wilkerson, who, as you all know, has written 2 phenomenal books about racism in our society since that time. But anyway, let me stop there, and I'm looking forward to the discussion, and I am totally honored to be here, especially honored to be with both Barbara and David here. Thank you.
I think if we fast forward or if we advance another slide, there we go. So I'm just going to pick up a little bit about where Jim left off and bring us into a policy focus here. So just want to focus on a few things, and then let's get to a discussion I'm excited about. Passing this back to Ellen. So one thing, let's just talk about Medicaid. So on the left, if you look at this graph, this just shows the disparities in health coverage in the United States. And so you can see where the general population, largely privately funded, with obviously some Medicare and Medicaid put in, and then of course about 9% uninsured. In the light green, those of you who are familiar with federally qualified health centers or community health centers, these are safety net clinics that provide comprehensive primary care in an outpatient setting and support services like case management. But then you have healthcare for the homeless programs, which are a subset of FQHCs, and we do more with behavioral health, a lot more with support services like intensive case management and outreach and such. So if you can take a look too, about just over half of our patients now are on Medicaid, which is really great. You'll see that there's very limited role for private insurance at this income level. But I want to point out that about 1/3 of our patients nationwide, and we serve nearly 1 million patients a year in healthcare for the homeless programs, about 1/3 are uninsured. Now, a lot of this As David pointed out, living in Miami, 12 states have yet to expand Medicaid, which again is not only a moral failure, but really a healthcare failure for all of us. So if we shift over to the graph on the right, you can see this is just healthcare for the homeless programs. So the graph on the right is that million patients that we were seeing last year in 2020. And you can see the disparity in coverage, whether you are in an expansion state or a non-expansion state. And it's literally the inverse. So when we talk about coverage issues for this population, we are primarily talking about Medicaid. So for those of you in the audience who are Medicaid folks and are doing advocacy or policy work in this area, there's a couple of things I want to point to. One is that lack of access to insurance coverage, as I'm sure you are well aware, is specifically tied to not being able to access health care at all, ongoing poor health, and not having anyone be able to have anyone responsible for their health care in the system. That's where we see a lot of ad hoc emergency room visits, hospital admissions, and things like that. But that is, none of it really kind of comes to any kind of coordinated care. And what Jim and David both talked about is we need continuity. We need comprehensiveness. We need basically to do the kind of model of care for this population that we would want for our own self. Second, even when you do have Medicaid, we all are familiar with the churn of maintaining eligibility, the limited networks of even willing to see Medicaid patients, let alone Medicaid patients that bring with them complicated healthcare issues. So willing providers. And then frankly, just the paperwork undermines the benefit. So a lot of prior authorizations and the paperwork and administrative hurdles of even delivering timely care to patients really is a problem. So anything that can make that administrative piece of continuity of eligibility, a comprehensiveness of networks, and getting our reimbursement rates up to the point where we have willing providers. And so finally, on the policy needs, lots of areas that we can focus on improvement here. Obviously, closing the coverage gap. So in the 12 states that haven't expanded yet, we need to have an option for people, because it's not an exaggeration to say that people are dying without Medicaid coverage. Second, we need 12-month continuous eligibility. This is just the kind of thing that is taken as a standard in other health insurance programs. We need to make this a standard nationwide in Medicaid. Obviously, increasing reimbursements so that we can be bringing provider rates up to the point where we can deliver care. Adding optional services. We talked about supportive housing and other things that you can make flexible in your Medicaid plans to add those tenancy supports and other issues. I want to talk about medical respite care here in a second, just as an example of this. And then finally, COVID has shown us the real importance of telehealth as an alternative to in-person care, particularly for people who do have phones who can be, again, care can be delivered pretty effectively for chronic care management and other check-in kinds of things. We've seen tremendous benefits from telehealth here, but it means that you have to recognize an audio-only telehealth benefit in your Medicaid program. And again, this is the kind of thing where we need to make conscious policy decisions to make Medicaid a better program to specifically serve this population. I know we want to get to discussion, so if we go to the next slide, under that rubric of adding additional services, making Medicaid work for us at the state level and use the flexibility that we have in those programs. Both David and Jim talked about the importance of medical respite care. So for those who are new to this is post-acute medical care for people who were homeless, who were too ill or frail to recover on the streets, but not ill enough to be in the hospital. So when someone's ready for hospital discharge, as David said, ideally, they have a safe discharge to a stable place. Absent that, though, when you and I would be sent home to rest and recuperate, where does somebody go if they don't have a home? Shelters are uniquely not suited for dealing with a lot of healthcare issues. In fact, most shelters close during the day. You can't stay there all day. So this is where we're looking at how do we come up with medical shelter beds staffed with medical providers, case managers, therapists, community health workers, a team of folks that can really help stabilize people while they are recovering. And this gives folks an opportunity to not only get connected to primary care, behavioral health, specialty providers, develop an ongoing care plan, have really a few weeks or even a few months to work with someone on their medication management, on their own chronic disease management, and be able to get a more stable plan so that people can get discharged from medical respite care back into a more stable environment, or at least when their health is in a more stable place. This has got a lot of benefits to the healthcare system, namely shorter lengths of stay in the hospital by giving hospitals an outlet, looking at fewer readmission rates so that as people are stabilized, you kind of can interrupt that cycle of admission, readmission. Obviously, we're seeing better health outcomes when we treat people in a more comprehensive way with more continuity of care. And then finally, of course, for those who are really focused on the money piece of this, this does lower costs throughout the system. And so again, thinking about how we can be delivering better care is really helpful. So the policy need here, recognizing that there is a need for medical respite care and providing that space for people who are homeless coming out of the hospital, and then adding those services into your Medicaid program. Happy to talk a lot more about this, but I do want to just mention that in the last 2 days, for those of you who are at the National Association of Medicaid Directors Conference, what I was really impressed to see in the last couple of days is at the highest levels of Medicaid talking about how do we make these programs work for social determinants of health? How are we using Medicaid to be innovative and meet the needs of more vulnerable people? And so I think medical respite care is an ideal application for this and builds on the work from the tenancy supports and supportive housing that Medicaid has focused on for this population in the last several years. So really excited about that. Also want to talk about the Build Back Better legislation that's currently being considered by Congress. The investments in housing and the changes in healthcare that we need to have in order to make inroads here are really important. And so for anyone who's doing any work in that area, please understand that those components are really important for us and for this issue here. If we go to the next slide, and this is just my third issue. Again, I wanted just to focus this around a few issues here that we can talk about in our discussion. Also happy to branch out beyond that, but we can't talk about any of this without talking about harm reduction. David talked a little bit about trauma-informed care, which is also a piece of harm reduction, but really what we're trying to do is reduce the harm that's coming to people. Now, typically this is, when you talk about harm reduction, we're rooting this in what patients or clients want to see for themselves and their own goals. It's often used in a reference to substance use, but certainly not exclusively so, because it can apply to a broader philosophy of care. So when we think about how we practice, and Jim talked about this, we don't want a doctor who's just looking to do this as a part-time side gig. How is it that this is part of our committed team's work to be able to do outreach, street medicine, meeting people where they are, doing more flexible care? We tend to have very rigid systems set up in our systems, right? You're 15 minutes late for an appointment, you can't get in. If you were running late, or if you didn't have the paperwork in order, you don't get served. And that just doesn't work for this population. So again, how are we removing the barriers so that this population can get connected better to care? And then how do we think about that is in terms of our public health approaches? So I think COVID-19 has certainly illustrated not only the connection between housing and health, but also the importance of taking public health approaches to homelessness. So when we think about syringe service programs, making fentanyl test strips available, distribution of Narcan, things that are making overdoses less prevalent. I think that we just saw the headline this morning that we've now hit 100,000 deaths from overdose. And that is just an epidemic in and of itself. As we think about moving towards safe consumption spaces and other really innovative ways of being able to meet people where they are, reduce the harm of behaviors, and keep people alive so that we have another day where we can do the outreach necessary to get them connected to care. So I think a lot of this is just thinking broadly about how do we improve systems, how do we elevate staff training so that we've got good communication skills and good ways of approaching patients in a way that's engaging rather than alienating, and how do we really expand public health policy approaches so that we're not scared away from all the typical, syringes and all of that. We need to meet that head on as a way of acknowledging the problems that we currently have. With that, if we just go to the next slide, I believe the slides will be made available. I've just got some resources here that we've put out around a number of these areas. When these get available, we're certainly happy to share the links here. But with that, really, I'm going to turn it back over to Ellen so that we can get started with our discussion. And really interested to hear what's on your mind and what areas here that we want to talk about. So thank you.
Great. Thank you so much, Barbara. Thank you, David and Jim as well, for your perspectives and expertise in grounding this conversation. And we're going to dive into our Q&A portion, just a reminder, you can submit questions using the question mark button on your attendee interface. And I have some follow-up questions that I'd like to ask, but we have some questions that have already come in through the chat. So I'm actually going to kick it off with questions from the audience. And just a reminder to all of you out there as you're pondering what you'd like to know, this is an all-star panel, experts at the top of their field, and it's a really unique opportunity that you have to ask follow-up questions from Barbara, David, or Jim, pose any kinds of questions or challenges or suggestions that you want to. So please tap right in there and let us know what you're wondering about. So I'm going to kick it off. We have a question about medical respite care, asking where has medical respite care been tried, what studies have evaluated it, and how has the program been targeted? So I don't know if that's for Barbara, because I know you tackled that, but anybody?
I'm happy to start, but I've already talked, so I'll turn it over either to Jim or David to talk about medical respite. Certainly Jim is one of the founders of medical respite.
Yeah.
Yeah, no, I'd be happy to throw it out, and David, jump in when you need to. But so our experience now has been a long arc through the last 36 years. And so we realize that the definitions of respite care can be very local, depends on what you may need in your local situation. What we have found, we have now 104 beds in our main respite program, 20 in another one. And prior to COVID, you know, every time there was an open bed, we would get 20 calls for it. So it's not even, the need is huge. It evolves over time, though. I have to be careful on this. So whereas initially we used to think it was for people coming out of the hospital, about half of the people are coming out of the hospital. The other half is a really interesting mix of people who, for example, need IV antibiotics for a while. They don't need to be in the hospital anymore. People who really need day surgery, who need a place where they can come, then be delivered to the hospital for their surgery, picked up after anesthesia, and to have post-operative care. We have a lot of people who are end-of-life care. They have no place to go. And we're also evolving now. We've got a lot of people who have been on the streets for a long time now in housing, and they're in single apartments somewhere. And when they get sick, they have no one there. So respite is becoming sort of also a kind of a safe place for people to recover for all sorts of things when they are alone in their homes. So I think you will, if you look around the country, you'll find different needs emerging. And respite has always had to try to be flexible enough to address those particular issues. Our respite program, for example, one floor became a COVID inpatient unit during COVID. So we had to give up a lot of the other stuff to do just COVID. But anyway, let me stop there. David, you may have more. There's all sorts of funding issues and all sorts of development issues, which we could talk about, but that's kind of the mainstay.
Yeah, I really can't talk too much about the funding issues. Those are the types of things that we're exploring right now. Here in Miami, I just can really, unfortunately document the compelling need for some type of solutions for individuals who are being discharged from a short-term acute care setting because they're not sick enough to fit within the DRG that would justify them being in the setting. But they simply don't fit within long-term care, for instance, settings either. You know, they kind of fall in between that crack. And that is, you know, here in Miami, for instance, a very large number of people. We've got a colleague physician who's internal medicine finishing up her residency, and she just tells me on a daily basis, there's like a half a dozen, anywhere between 4 to 6 people every single day, different folks, you know, who are unhoused, who they're frantically trying to find a place to place them that's not on the sidewalk. And because we know that once you discharge on the sidewalk, their health condition status is going to plummet. In fact, we have documented instances, as I said, of people having devastating consequences of dying just literally across the street from the hospital. So the need is there, and we're hoping, I think, through initiatives of the National Healthcare for the Homeless Council, we have established a new institute, National Institute for Medical Respite Care, that's going to provide technical assistance, that's going to help to find those sources of fundings and to connect communities with those fundings. And so I would encourage folks to go to our National Healthcare for the Homeless, National Healthcare for the Homeless Council website and connect with the National Institute for Medical Respite Care. And I think we can find some solutions to finding funding and establishing respite programs in communities.
Great, thank you, David. And
if I can, I'm sorry, I just want to, real quick, I just want to say that thanks for the shout out for NIMARC, or the National Institute of Medical Respite Care. Just to answer to the question, there's about 120 medical respite programs nationally that we're currently aware of. And most of them are funded through hospital grants, or local private foundations are grant funding this, but we're seeing a lot more interest from Medicaid systems. California, in their CalAIM, is going live on January 1 with an in lieu of service for medical respite. Washington State right now is pursuing a statewide benefit. Utah is putting in an 1115 waiver for medical respite. New York, Michigan, Colorado, all of these states are really looking at how they can be more flexible with Medicaid on medical respite. So just wanted to give that context too.
Great, thank you so much for that, Barbara. Very concrete, and it tells our questioner that this is a practice that is really making progress. I want to remind folks that we did extend the time for today's webinar. We knew that we would have lots of questions, which we do. So just want to remind folks that we're here until 1:15. So keep the questions coming, and we'll keep the policy and community insights coming. I have another question here. I think it goes to David, and certainly Barbara and Jim, feel free to comment. And here's the question, going back to trauma-informed care. I understand some people may be so traumatized that they lose trust in the healthcare system, and this would probably lead to some cases of non-compliance. How can we better facilitate trust, and what programs can we be aware of to help this high-risk population? So I think would love to hear each of you a couple of remarks on that question.
Sure. Trust is a big deal. You know, as I mentioned, because people are so emotionally and physically traumatized from living on the streets, you just feel vulnerable to quite literally everybody. And so the normal systems, normal institutions that I think house people might trust are considered to be a threat to folks who are on the streets. You know, such as police, for instance, are often viewed as predators and not so much as protectors. And doctors as well. And people just have a general feeling that they're only out there to get us in for our Social Security numbers, you know, to get our food stamps, you know, and to get our money, and that they don't have any real security towards you know, improving our health. So peer support specialists, I think, are a huge effective way, because these are individuals who have overcome the challenges of homelessness, overcome the challenges of addictions and mental illness, and stabilize these conditions. And so they're coming from the streets, or they're coming from that setting, and they're much more effective in terms of connecting with people. And again, it's extremely important to do this under the rubric, under the umbrella, under the paradigm, if you will, of a trauma-informed system, and not so much trying to coerce people and look down on them in a judgmental fashion and try to get them to change their behavior, as much as looking at the systemic structural issues that created those conditions for homelessness. I'd like to say that homelessness is a choice, but it's not a choice of the people who are homeless. It's a choice of the politicians who have created the unfortunate conditions that have led to homelessness. So if we stop thinking that people want to be homeless by choice, or they're all just drug addicts and mentally ill, and they're there because of character defects, or they're just bums, I think that's a big way towards changing the way that you approach people, to reestablish that trust that allows you to bring them in.
Great, thanks, David. Other thoughts, Barbara, Jim? Got some other comments coming in, but go ahead.
I think, you know, I'm just listening carefully to what David just said, but I think trust is one of, I mean, it's fundamental. And the key to trust is time, and time is one of the things least valued by the healthcare system, at least by the reimbursement part of the healthcare system. And I think, you know, we all have our own narrow lens of things, but for me, trust took years. You had to like be there. You had to be present. You had to stand with people. You had to take care of them, and just be on their faces. I know that when I first started, you probably know this story, but the nurses in the clinic that I went to, I was a doctor, we're trained to be, you know, be quick. We've got to make diagnoses, treat, you know, move on to the next person. And the nurses made me spend 2 months doing no doctoring, but just soaking feet. They had a they invited people into the clinic and they soaked their feet, and I had to like stop at my 125 miles an hour and go just soak people's feet for 2 months. And that earned so much trust. And I keep thinking the investment in that time was probably what gave me the best version of stuff. And the other thing I've learned is, getting out to where people are and not expecting things to change right away is a key component of trust, that people are going to have to get to know you and get to see you. And using peers, which I've always had the blessing of working on a van that goes overnight that's run by one of our local shelters with Department of Public Health money, goes out every night from 9 at night till 5 in the morning, combs the city, brings soup, sandwiches, and blankets, and we get to ride along serving soup and sandwiches and blankets, and then say, by the way, if you need anything, I'm a doctor. And we've learned that that back door is frequently working with the, with all the people that David has described, is really a key. And when you step back and think about that, it's very hard to orchestrate in most of our healthcare settings. So some of the things that I would urge Medicaid and everyone else to think about is, how do you fund that time in between that is so critical?
Great. Barbara?
And Ellen, I would just finish by saying a way for us to think about this in not only in healthcare practice, but also healthcare policy is, in order to have patients trust us, we have to be trustworthy. And so what does it mean for us to be worthy of trust? And Jim and David just described how we need to be changing in the healthcare sector, in the delivery of our services. We need to be worthy of that trust. And I think that starts with not using terms like non-compliant, because we really need to be thinking about, well, why didn't someone take their medication? Maybe it's because they're living in the shelter, or they had their medication thrown out by the last encampment suite. So I think we need to go deeper.
Mm-hmm. Great, thank you. I have a direct follow-up on respite care question. Do medical respite programs address health needs of pregnant people who are experiencing homelessness? In your experience, or maybe Barbara, you might have insight given your role.
I don't see any reason why not. Certainly, if there's medical needs that can be accommodated in that setting and it's appropriate for that setting. Now, medical respite care, it's important to say, is not a replacement for skilled nursing. It's not a replacement for nursing home or higher levels of care. So it is specifically for non-acute, does not need that level of acuity. However, certainly if a patient is pregnant, that we can address their medical needs. But Jim, am I talking out of school here on clinical work?
No, never, Barbara. We've had lots and lots of pregnant women. Respite can be critical because often, all the examples that come to mind, we've had some women struggling with cocaine, living in tunnels, who would only go to some place like a respite program where it would be people that would accept them, where they would stay. We've had lots of examples of finally luring people in, and the women will stay until they deliver, and we can make the connection, get them into the prenatal care or do the prenatal care, and then get them to where they can deliver. And some of those experiences have been the most rewarding we have had. So the answer is certainly yes. And the only thing I would say with Barbara is the level of acuity is going to depend on the type of respite program you have. And we have 24-hour nursing around the clock. We have psychiatry, we have medicine. So you can, in some ways, develop more acute things where you can work in concert with the hospital. And with pregnancy, it's rare that you have to go to the hospital. So doing that care and respite is actually something the hospital helps us with. So that's kind of another angle in.
Great. We have another question, actually kind of a comment too, I guess you could say, is do jails also release into the streets? So
I think
all the time.
On that one.
Every day, right? Another comment and question here from a participant. I found the point about continuity of care to be particularly pertinent. One of the things that evokes for me is the question of how to attract and retain physicians early on in their medical career, who recently completed medical education or residency in the shadow of medical student loan debt and loan forgiveness programs targeting physicians in high need areas. Do they apply when working with unsheltered populations as well? So would love to hear from any of our speakers about that topic.
I'm happy to go on that, but I'll bow to either of you guys. This is a topic near and dear to my heart, by the way. Please go.
Jim, I think this is squarely in your bucket.
You know, just a little personal side is when the National Healthcare for the Homeless program was started, it was started with the express purpose, and the problem that brought up by homeless people is how come doctors are not out in the shelters with the nurses and other people? And it was how do you attract doctors? It was just that question. And the answer was pretty careful. There was no career path for this. There was no place you could go and work and live and sustain yourself and do this. You could only do it as a short time and then go on and do your stuff. So one of the mandates we had, Dr. Phil Brickner was the head of our program back. He was at the head of community medicine at St. Vincent's. He oversaw the program. But it was how do you get residents and students and everybody involved in the care of homeless people? And that's what I think if you look around the country at healthcare for the homeless programs, whether they're in health centers or freestanding, you will see that they are really wonderful places for students to come and take care of people and work side by side with the clinicians and nurses and the teams who are taking care of people. And we never had that. When I was in medical school, there was no opportunity to do that. And the only jobs you could get would not pay you a living wage. So you had to always do this as a volunteer thing or something on the side. But we're, over time, when I think of the doctor, we have we have close to 40 doctors working in our program now. Almost all of them came through our program when they were residents or when they were medical students. And we have even more nurse practitioners and PAs, so the same for students there and social work students, et cetera. So I think having a vibrant educational component of healthcare for the homeless programs offers a way to regenerate or generate a workforce that's willing to do the care that we've all been trying to describe.
Great.
I would add to that maybe a different angle here. Increasingly, you are hearing about burnout amongst clinicians, particularly driven by moral injury. They're working in a system that does not allow them to practice medicine because there are so many factors that are undermining their work, homelessness just being one of them. And so as we're seeing more clinicians get angry at the conditions that they are being asked to work in and treating patients that are not in a position to be able to do care plans because of other factors. Again, this is that social determinants of health piece. I'm seeing a lot more young physicians want to get active in advocacy, want to change the systems that they've been asked to work in. So medical debt certainly is obviously one worthy area, but I'm just thinking about how is it that we have our student medical groups who have been more active in state legislatures, more active in their advocacy federally to ask for, why is it that my patients don't have housing? Why is it that my patients can't afford food? I can't write a prescription for housing and I can't write a prescription for food, but yet everything I'm going to do here is going to be undermined by the absence of those things. And so I'm really excited about not just us having more internships available to do this, but having more medical schools, nursing schools, pharmacy, all of our professional schools doing more on poverty, medicine, and social determinants of health, but giving pathways for our young doctors and new people, new clinicians coming into the field to be able to change the system so that it works for them and allows them to practice in the trades that they've been educated in.
And I think you can agree, David, here, and we'll add law schools in there too as well, right?
Can I throw I'm sorry, go ahead.
Well, I have another question. And we're coming close to the end of time, we'll see. But maybe want to kick off here, Barbara, with your thoughts on this, which is what are the early first steps that states can be thinking about in terms of getting more street medicine covered by Medicaid? And you've talked about some of those, but maybe you want to expound a little more.
Sure, street medicine. So basically identifying the providers that are poised to do this. How is it that your reimbursements or what's preventing people from billing for the services they deliver on the street? So oftentimes there are rules governing where you can deliver services. Are those too rigid? Do you need to establish specifically a street medicine benefit in your Medicaid program that allows that flexibility? A lot of times in a managed care system, for example, Jim can be on the street and he can be delivering care, but if that person, he's not the enrolled provider to that patient, then Jim isn't able to bill for his services. So again, making sure that we can be more flexible so that providers get paid for the care they're delivering to a client and making that more flexible. So because Medicaid differs so much from state to state, it's going to depend on the specifics of how your plan is put together. So you may already have the authority to do this, or you may need to craft something. But happy to talk more about that in another setting, but definitely there's ways that you can be more specific. And Jim, you may have some thoughts here too, since you are a street medicine doc.
No, Barbara, I think you articulated it really perfectly. I think the issue, Ellen, that we always run into is the work you're doing as whatever profession you're in, whether you're a doctor, nurse practitioner, PA, the work you do in the street should be billable if it's a medically necessary, et cetera, the way Medicaid sets it up. And we've learned that almost everything you do out there is potentially billable. The question is, can you then do that? So one thing that I would just add that's going through my mind, and I didn't say it very well, but you know, our consumer board, by the way, we have 5 to 7 homeless people on our board of directors, and they still tell us what to do, and it's the best thing that ever happened. But you know, we still are required to stay part of the hospitals. And I look around the country, and I wish the hospitals would get more clinically involved with healthcare for the homeless programs, because if I'm taking care of somebody under a bridge who now needs cardiac surgery, you know, because I'm part of Mass General, I don't refer this person in for anything. I just make the appointment and then see them. And that is huge to a homeless person. That's what our board members want. They want to know that they are part of a system. And every time I see us being pushed out to the edge, I get nervous. And the more I see us being part of, embraced as part of what big hospitals and academic health centers should be doing, and I would argue this is as complicated a work as they should do, so medical schools, nursing schools, all that. But it's hard to get them to embrace that, other than to maybe give us some money and say, thank you, you're doing good work. I think we should force ourselves to get integrated. You know, like our doctors have to attend on the wards, we have to teach medical students, we have to have clinics on site in the hospital, so we're seen as part of the, you know, structure of the hospital, and the care given to homeless people is not seen as something that is separate from or out there from. And I think that's a challenge, but the reward is huge, and it answers many of the questions that you just mentioned.
Great, thank you for that. And I've just been given the warning here that we're almost out of time. And I just want to thank our panelists for your insights on these topics. Just really compelling and essential information. Thanks to all of our participants for your time today. Please take time to complete the brief evaluation survey that you'll receive immediately after the broadcast ends via email later today. Join the Alliance tomorrow for their Voices from the Front Lines program, where you'll hear from an incredible lineup of public health workers, community service workers, and public service figures about their contributions to public well-being throughout the pandemic. And a recording of today's presentation and any additional materials will be available on the Alliance website. So this concludes our time today. Thank you so much to everyone for joining us. Thank you especially to our panelists for your wonderful insights and expertise, and have a wonderful afternoon. Thank you, everybody.
Thank you.
Thank you.